Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today, I'm talking to Professor Debi Bhattacharya about deprescribing to optimize drug therapy. Could you start by introducing yourself?
I'm Debi Bhattacharya and Professor of Behavioural Medicine at the University of Leicester. I lead a research team at the University of Leicester, and we're focusing on applying behaviour change methods to improve health outcomes. So I've worked for decades in the field of medication adherence, and over the past sort of 7-8 years in the field of proactive deprescribing. And so as a team, we work with national research funders, local NHS organisations and industry to design and implement strategies to positively change behaviour. So that might be patients or it might be healthcare professionals. I'm also director of Leicester's Pharmacist Independent Prescribing course, and my clinical background is as a primary care pharmacist.
I want to focus on deprescribing. So could we start with a definition? What is deprescribing?
So deprescribing is often thought of as a homogenous behaviour. You know, it's one term, deprescribing. But in 2018, we defined two distinct behaviours, and that's reactive and proactive deprescribing. So reactive deprescribing is when a medicine stopped in response to an actual clinical trigger. So something bad has happened. And that might be something like stopping an ACE inhibitor in response to acute kidney injury, because the ACE inhibitor will make that worse. And this behaviour requires limited clinical decision-making and also limited patient involvement, because the action needs to be taken to prevent further harm. Proactive deprescribing, however, requires often quite a difficult balancing of the likelihood of future benefit versus future harm. So it's a much more complex decision that absolutely has to be made in partnership with the patient.
So why is deprescribing even necessary? Surely nobody would prescribe a drug that does more harm than good.
You're absolutely right. No one sets out to prescribe a medicine that does more harm than good. But what happens often is the balance of benefit and harm changes as a person's circumstances change. For example, think about how many people have a blood pressure started in their 40s. And then, and that's when we have a highly stressful life and lots of other things are going on. And that may no longer be necessary when we're in our 80s. And in fact, it could actually be harmful because it increases the risk of getting dizzy from low blood pressure and therefore having a fall. So this sounds like an easy ask to proactively deprescribe a medicine before it causes harm. But there are challenges. So our international survey of practitioners that with a role in deprescribing medicines actually reported that historically, and I know this as a pharmacist myself, we've often introduced medicines to patients as being for life. And so suddenly stopping them, particularly later in someone's life, can be quite alarming for them. Kind of a feeling that we're de-investing in them rather than making a positive decision to improve their quality of life. So there are, it's definitely a much more difficult thing to do. And actually, when we did focus groups with NHS hospital doctors and pharmacists, they also identified that they feel that the kind of culture, the prescribing pathways, things like NICE, emphasize situations when medicines should be started. Like thinking about NICE guidelines, but they don't explicitly provide guidance on when and how to stop medicines. And then, of course, the other element is we need to fully involve, as I alluded to earlier, involve the patient in decision making, because it involves this balancing of patient priorities with prescribing guidelines. Because the prescribing guidelines will say this person should be on an antihypertensive, whereas patient priorities and our clinical judgment may say, actually, perhaps this is no longer the right thing for our particular patient. And so this all takes time, which is a significant challenge to deprescribing.